Hello, and welcome to this second ACARE Level Up webinar. Warm welcome from my side. My name is Thomas Buttgereit from the ACARE Berlin, and I'm here with you, with my esteemed faculty. Welcome and thank you to have you, Dr. Anete Grumach from the University Center and Medical School of Sao Paulo in Brazil. Good morning, Anete. And also a warm welcome to Professor Dr. Marc from the University of California, San Diego. Also a warm welcome and good morning, Marc. Great to have you here.
Good morning, good to be here.
So in this second webinar, it's a very special webinar, and I've learned that this topic is something the angioedemologists love to hear about, love to learn about. In this webinar, you will learn about the current definition and the types of HAE with normal C1 inhibitor. And we as a faculty will also discuss how we can establish causality of this, of probably new and not yet described mutations for angioedema. And for this, we designed a very nice and tough agenda. So Anete will start to talk about the evolving recognition of HAE normal C1 inhibitor. And this after this presentation, I will present two cases of HAE with normal C1 inhibitors. And on the final stretch, Marc Riedel will give a talk about the estimated prevalence and treatment patterns of HAE with normal C1 inhibitor in the US. And you will also have a discussion and question and answers session in the very end of this webinar. I've learned that many people have registered from all countries all over the world for this great webinar, and I really like to see this view here. So we welcome angioedemologists from Europe, but also from South America and from Australia, and as well from Russia and the Asian continent, and of course from Northern America, from the United States, Canada, and from South Africa. Happy to have you here and listen to us for this great episode of the ACARE Level Up webinar. This webinar is CME accredited, so you will receive 1 point of CME credits after you have completed the feedback form of this webinar. So you can see how to do it on the right-hand side with the QR code. So please do it to, in the end, receive the CME point. And if there are any questions, just to keep you, to remember this, please leave your comments in the question box in the Zoom window. And maybe you're also aware of the Level Up newsletter, where you learn about what is going on in the ACARE network, about its activities, and also new projects, and also something you would like to share. Please reach out to Julia Völl from the Galen and ACARE office to subscribe now. And you can also stay connected with us in the social media and websites by just using this QR code to get access to it. And I think now it's time to listen to the talk of Anete Grumach. And Anete, it's now time for you. Take it away, please. We are really excited about your talk.
Okay. Thank you very much for the opportunity to talk about this subject. It's very interesting. Then we will introduce the idea of HAE normal C1. We will talk about the evolving recognition of HAE normal C1. These are my disclosures. And our agenda, we will discuss the recognition, the nomenclature, some variants that we found, and final comments about that. So the history begins in 2000, when two groups reported HAE without SERPING1 mutation, with normal C1 inhibitor, And Conrad Bork and collaborators described 36 women with angioedema. So at this point, the idea of estrogen involved was important, the importance that only women were affected. This was reported in 2000. Then these patients were evaluated and they found, Sven Sichen and collaborators found factor 12, plasmatic factor 12 increased, the activity increased, but in 2006, the factor 12 gene mutation was reported. And then it was recognized that even not only women were affected, but also men were affected. They were less symptomatic, but they had the mutation. Following this, we had other, at the beginning, we had 2 mutations described, 2 variants, and in the next years, we had 2 other mutations, a duplication and a large deletion leading to factor 12 disturb, I would say. And we had the opportunity to describe two families homozygous for factor 12 mutations. This is the history, the initial history of HAE and normal C1. And I have to confess that we have several names reported, but everybody used HAE type 3. HAE type 3 because we didn't know pathophysiology, we didn't know how to describe, but recently we had a discussion about the new classification of HAE, of angioedema, and HAE with normal C1 will be described from now on from HAE plus the mutation found, or unknown if the mutation are not found. This is a publication with a study developed in ACARE with Abner Reshef and collaborators. We have few reports about the prevalence of HAE in factor 12, but it is estimated to be 1 to 400,000. And the definition until now, and it's a subject to be discussed, is that HAE and normal C1 patients present recurrent angioedema affecting 1 or more organs, no wheals, hormonal influence, positive family history, and this point is very interesting to be touched, and normal biochemical values. This is the classical definition of this group. I will show here some of our experiences about HAE with factor 12 mutation, and we can see here that the onset of the disease is later than HAE with C1 inhibitor deficiency. We can see here that mean age of symptom onset is 21.1 years. It represents most of the patients after the puberty. And this is something that we can see in our distribution of factor 12 mutated patients. And evaluating in comparison with HAE and C1 inhibitor deficiency, we can see here that it's true. The patients develop the angioedema later, and but most of them, I would say 86% of these patients are females. They are predominant in this group of patients. And clinical manifestations, we have the same, these are our patients, and these are the same symptoms. We have subcutaneous edema, gastrointestinal edema, airway obstruction as well, and also unnecessary surgery in 8% of these patients. And we can see the rate of asphyxia of 1 in 2 to 125. So the comparison about both groups, we can see that HAE factor 12 have patients have the same symptoms as the patient with C1 inhibitor deficiency. Let's see some differences. One is about the trigger factor. We see the hormones as a special trigger factor for all these patients. We can see here our experience in 42 Brazilian families and 130 patients. We can see that hormones are very important, and but the other trigger factors are present, like stress, trauma. So even dental treatment, pressure, weather, they are present in these patients. And regarding the influence of the hormones, we can see here that we also see that contraceptives are very important, and you will see it will be commented about the therapy of these patients. And so it's interesting to see that some of them, the withdrawal of contraceptives are very important to improve their condition. Also, some patients develop after pregnancy, and we can see here in comparison with patients with unknown mutation. Okay, this is factor 12 variant associated with HAE normal one, but then plasminogen mutation was described, and in HAE normal C1, and we can see also an autosomal dominant inheritance. We can see where the mutation was established, and in several families. We can see here not only female but also male affected. And one report from Conrad Bork, who described the mutation in these patients, showing several families. We can see also a predominance of female. It was not so intense like factor 12, but we can also see that the mean age of onset is 30.5 years. And even there is a description of even older patients presenting angioedema after 60, 70, even in other reports. But it's interesting to compare the HAE factor 12 with HAE plasminogen patients. So the symptoms are a little bit different. And if you look the edema, they also affect abdomen, they affect the larynx, but or the extremities, but you can see here a very intense presentation on lips. So they, in face and lips, the patients present this edema, and in tongue, it was possible to have a significant difference comparing with HAE factor 12. So later onset tongue edema associated with other symptoms are probably associated with plasminogen, and I know that Thomas will discuss later some details. Let's move on the development in HAE and normal one. After, almost at the same time, we have the description of angiopoietin 1 mutation, which is a little bit different, not only in clinical symptoms, but also where the disease is established. And then we had the description of kininogen 1 mutation by Conrad Bork as well, myoferlin. And it's important to know that this descriptions and these variants described have very few cases. They report families, so we don't have the whole data that we have for plasminogen and factor 12 mutation. And most recently, we had the description about heparan sulfate, and this mutation was reported. And I will mention at the end one new publication talking about the role of carboxypeptidase N in dealing to angioedema, and some points because they present also virus in these patients. And we are going on with looking for new mutations, and we still have a lot of patients with unknown mutation. So regarding angiopoietin 1, also we had the description of autosomal dominant inheritance. We have one family, but we are still studying this family, and they present severe abdominal pain in one patient, mild one in others. Trigger factors are minor trauma and pressure. We can see pressure. The patients present bruising. This is an interesting thing because all the HAE normal C1 patients don't present erythema marginatum, and they responded to tranexamic acid. This is the group of angiopoietin. And we can see that it's different because it works in the vascular permeability, and so they present a little bit different clinical profile, I would say. But these are the first and only description until now. Then we have the kininogen 1 described. We have also the autosomal dominant inheritance. And this is interesting because this mutation could lead to anomalous bradykinin and modified cleavage. The triggering factors are also contraceptives and pregnancies. And this is one interesting point. Later in life, they onset the symptoms, and the symptoms are tongue, hand, feet, but you can see that we have only one report about kininogen 1 mutation. And finally, the last mutation that we have included as HAE and normal C1 until now is the heparan sulfate. And we have also affecting some points in permeability. And I collected the clinical data of 4 females. They had the onset between 12 and 20 years old, so not so early. No negative influence of estrogen, but look, we are reporting one family, trigger factors, trauma and stress, and 20% had facial swelling, and 80% affecting only lips. So something similar to plasminogen mutation. They had also abdominal attacks with vomiting and diarrhea. And I wanted to point out this new publication about carboxypeptidase N, and it's very interesting because it works in the catabolism of bradykinin. There are some mechanisms linked. There is experimental work showing that that edema can be triggered in these patients or in this experimental work. And this was reported recently in a family, but you can see here in the left that we have, okay, peripheral, abdominal, angioedema, but we have also urticaria. We have recurrent urticaria in these patients, and they were treated with tranexamic acid and icatibant. And this is something interesting to open a discussion about these patients. I prepared this kind of figure showing the symptoms in this reported in this group. And you can see that we have most of the patients with urticaria reported as urticaria associated with laryngeal, abdominal, and peripheral angioedema. So this is something that maybe we have to discuss. And just to show you that we have a lot to learn about HAE and normal C1. We are all looking for mutations that could explain these patients. And my final points are that HAE and normal C1 has been associated with different mutations. So this is now our biomarker, I would say. We have to look for genetic mutation. So genetic study is imperative in this group. Hormones have an important effect in these identified mutations. We have mostly seen in HAE factor 12, but looking all the other families reported, some of them present the influence of estrogen. The genealogy is very important and necessary to confirm HAE in normal C1. It's not always easy to find out family history, but it's an important point until now. And I will repeat here one comment from Dr. Conrad Borg, that each HAE normal C1 type has to be considered as a distinct disease entity. And I think this completes my presentation. Thank you very much.
Thank you very much, Anete, for this very nice talk. We are very good in time. And I think I will continue directly with my talk to move forward here. So that there's much room for discussion in the end of the webinar. So yeah, as you see, this are my disclosures of my talk. And as you see, this webinar is really some topic for advanced angioepidemiologists. And that's why I like to present two cases of patients I have seen. So the first patient is a 25-year-old patient with recurrent angioedema. And the swellings of these patients started when he was 21 years old, so quite late. And the locations the angioedema occurred were the eyelids, lips, hands, and the abdomen. And when I asked the patient how long the durations persist, the patient said, well, actually only 8 to 24 hours, but the patient never had wheals. And he's otherwise a healthy person, does not take any medication, and has no comorbidities known. And when I asked for the family history of recurrent angioedema, he said that he knows from his mother that his maternal grandmother reported about swellings when she was, I think 25, 26 years old. And here you can have a look on some example pictures. Also on the left-hand side, you see a body map we use in our ACARE registry, CARE, which really gives you an overview where the swellings occur, also in the abdomen and extremities, but never so far in the upper airways. So what was the usual procedure I did when I see patients with recurrent angioedema? First of all, I asked the patient, do you have hives? No, he declined, no medication was taken. And the patient already came with values for C1 inhibitor, which were all normal. So there was actually, for the moment, no hint that there is HAE due to C1 inhibitor deficiency. And the patient also had no wheels. So this is also a challenging situation for clinicians. But in this situation, I recommended to start with antihistamines in the standard dose. And I used cetirizine and loratadine, but this failed to relieve the patient from his symptoms. And as a next step, I increased the dose to the 4-fold dose, like in urticaria guideline recommends. And I used Ebastine for this 20 milligrams, 2 tablets a day. And I also changed the medication to fexofenadine because the patient was living a bit more far away from my place, to switch in case the one antihistamine is not tolerated. But this treatment also failed in this patient. So it was a bit challenging situation, but for this, the algorithm we established is to treat the patient with omalizumab as an anti-IgE antibody. We know it works very well in chronic spontaneous urticaria, which is defined as Reals, angioedema, or both for more than 6 weeks, and the patient had angioedema only, never seen Reals. From the clinical trials, we know that omalizumab works very well in chronic spontaneous urticaria, and there are some late responders of omalizumab. So I gave it a try to treat these patients for about 6 months with omalizumab, and I saw the patient again, but he said omalizumab failed. So as a next step, I then did what I usually would do in this case, and also what the guideline for HAE recommends, to test these patients for mutations known to cause HAE with normal C1 inhibitor. This is how the guideline, how it's written down in the guideline. And for this, I was happy to have the ACARE project Imagine there to do this diagnostic workup. And what came out of this was finding, which is called the variant of uncertain significance in the plasminogen gene. And you see here, this mutation causes an amino acid change, but this variant of uncertain significance has not yet been defined according to the ACMG guidelines. But what I then tried for this patient to test, I prescribed this patient icatibant as a B2 receptor antagonist to treat his attacks, and he used this treatment to treat his abdominal attacks, and he reported that the symptoms started to resolve within 40 minutes. So there was strong hint and signal for bradykinin mediated mechanism in this patient, and I really thoroughly asked the patient again if there are any other family members affected beside the grandmother. And on request, we called his mother, and then the mother reported to suffer from abdominal attacks since the age of 14, but she never talked about this with his son, and also not with her friends and family. So they got all tested, and we saw that not only the grandmother, maternal grandmother, but also his mother was affected by this mutation. When we compare this variant with the clinical symptoms which we know from patients with HAE due to plasminogen mutation, we see some differences, but also some similarities. So first of all, which is the same as the quite late onset of the disease after the second decade. As Anete said, they tend to be more female patients, but this patient obviously is male, but also has some females affected in the family. By the way, his sister was not affected by this mutation. The patient had, as you saw, extremities swellings, also facial edema, abdominal attacks, but the patient never had so far laryngeal edema and no tongue edema, which is also more commonly described for patients with plasminogen mutations. So, but the response to high-dose tranexamic acid, usually they respond well. What was known from the literature has not been established by me. So when we look more closely into the literature, what is known about mutations in plasminogen described for HAE normal C1, we find these initial publications, as Anete introduced already, described by Konrad Borg, but also by Georg Dewald. And these mutations, which have been described, cause a plasminogen acid change in the Krangle domain of the plasminogen. And this may lead to an increased formation of plasminogen, which activates the kinin kallikrein system and eventually also cause increased bradykinin formation. So this is what was hypothesized, and which has also been shown in recent publications by the group of Dickerson, where they did experiments, very basic research experiments with patients and their mutations in plasminogen, and they saw that this mutation described were able to the plasminogen directly to catalyze the kinin release from the high molecular weight kininogen and low molecular weight kininogen, and they raised the proposal that there might be treatments that could fail, like C1 inhibitor supplementation or plasma kallikrein inhibition, to treat these patients with these mutations. The same like mechanism was described by another group recently published 2022, where they could show that this K330E variant mutation of the plasminogen may bypass factor 12 kallikrein system, as you can see here in these experiments with the Western blot using proteinase inhibitor and without proteinase inhibitor. They could show that there is probably a gain of function mutation of this plasminogen gene, which enables to cleave the high molecular weight kininogen directly, efficiently, with and maybe bypassing the factor 12 kallikrein system. So as I said, what's known to treat these patients, what Konrad Borg has published is that they observed a very good response to bradykinin receptor antagonists, which is a strong hint, like in our patient, that this angioedema is bradykinin mediated. And they could also show that the tranexamic acid, many patients responded very well to these treatments, which also supports that the fibrinolysis is involved in the pathogenesis of HAE with plasminogen mutation. And when you look in the very recent literature, you see even some cases where patients with the plasminogen mutation, one patient responded very well to lanadelumab and kallikrein inhibitor here. As you can see here, patients with factor 12 mutations, but also one patient with plasminogen showed response in the AECT, as you can see, and also improved in the quality of life questionnaire. So the question is now, the mutation of unknown significance, is this in this new variant, should it be regarded a genetic polymorphism until the laboratory tests, as you have seen, confirm the causality, or is it reasonable to say this type of angioedema is caused by this variant due to the good response to the icatibant we have seen by using first-line, second-line treatment options? I think this is something we really need to discuss and have an opinion on this. And on the end, and final end, do we also need uniform laboratory tests to confirm the causality of new variants that have been identified? So on the last case, it's a very short one, a 24-year-old female with first manifestation of recurrent angioedema when she was 24 years old. Here you can see swellings of the eyelids, lips, and hands, 2 attacks per month. But also when she was in the ER, ascites was seen and thickened bowel loops, and the high-dose prophylaxis with antihistamines failed. When we asked for family history, which was positive, her mother was also affected in her youth, but she didn't take any other medication beside a contraceptive pill since 1.5 years. So, and this was a gestagen estrogen pill. So when we think about this situation, one diagnosis comes into our mind: is it HAE type 1-2? There are some arguments for this. So we have the positive family history, the estrogens, we have the non-response to antihistamines, and the common affected areas, but the relatively late first manifestation. And what you see here, this patient was normal for C1 inhibitor levels and C4 and tested again. And we found a heterozygous pathogenic variant of the factor 12 gene in this patient in the IMAGINE project. And yeah, the reason for the attacks were obviously the estrogens, the pills she was taking. What is known is, as Anete already introduced, that mutation factor 12 gene potentially cause a gain of function mutation leading to overproduction of the factor 12A. And also the activation loop of the factor 12 is more exposed, and factor 12 becomes more sensitive to the activation of plasmin and plasma kallikrein. So what we did is we stopped the pill, the estrogen pill, and changed to a estrogen only pill. And after this, no further HAE attacks happened. So she did not have to use the icatibant. And we now plan, I think in the next months, the test of her mother for the mutation. So what are the learnings? Yeah, so I think it's important to test for mutations in patients with HAE normal C1, where we see a failure of high-dose antihistamines and omalizumab treatment. And in my opinion, from the clinical cases I've shown, the response to the on-demand treatment, which are approved for HAE due to C1 inhibitor deficiency, may indicate a bradykinin-mediated mechanism in these patients, and could be used. But what we definitely need more are clinical trials to investigate the effects of the first-line treatments we have so far for HAE to have a better treatments for our patients. And with this, I would like to thank you for listening and would love to hand over to Marc. Marc, I'm excited about your presentation now.
Thanks, Thomas. Really appreciate it. And hello to everyone out there. And thanks for the invitation and opportunity to join this esteemed faculty and say a few words about this really interesting and challenging topic we've been discussing. So I'm going to talk a little bit about, I guess, our experience and some of the data we've generated grappling with this diagnosis of HAE with normal C1 inhibitor in the United States. These are my disclosures. And my goal for the next few minutes is to discuss the following. We'll talk about the current challenges of diagnosing HAE with normal C1 inhibitor due to our limited biomarkers. And you've heard about the genetic testing quite extensively and nicely in the last couple of talks. I'll talk a little bit about the expert recommended approach for evaluating these patients. And as has already been alluded to, I think this is an evolving field where we are having discussions about recommendations, and there should be additional publications coming out on this. And lastly, I'll show you a paper we published recently looking at a survey of US physicians who are evaluating and managing HAE with normal C1 inhibitor, trying to get a little bit at the prevalence, which is still, I think, a big question, and also about what are we seeing in the real world, so to speak, at least in the United States at the clinical level. So I'll start with a very obvious point, but I always like to bring back why we're talking about this. And we're talking about this because in our clinics, when we see patients with angioedema, our job is to get them to the right treatment, to an effective treatment, the right medicine for the right patient at the right time. And so when patients come in with angioedema, we have certain tools at our disposal. Those include taking a very detailed history, which I think remains probably our most effective diagnostic tool, but also, as you've heard, genetic testing and biochemical testing. And while this diagram is a bit of a simplification, I think most of us would agree that we're really trying to get at whether this is a mast cell mediated problem or a non-histaminergic, non-mast cell issue, which we believe in most cases is a contact system bradykinin mediated condition. And there are exceptions to this. So again, maybe a bit of an oversimplification, but in clinical practice, this works pretty well to get people to the right therapy. And as we all know, we have multiple types of HAE. We think we understand type 1 and type 2 quite well, and we have biochemical tests that are very good at diagnosing C1 inhibitor deficiency. But what we're focused on, of course, is on the right, this group of HAE with normal C1 inhibitor, where our usual testing does not determine the cause, our complement testing. And we think this is quite rare, but this is part of what I'd like to talk about is it may not be quite as rare as we think, depending on how you define or diagnose the condition. So I like this saying. John Dryden is a British poet from the 1600s. He wrote a lot of things, but confidence is the feeling we have before knowing all the facts. And I think it's the facts are that we still struggle a great deal in the clinical space with these patients that have isolated angioedema in the absence of hives and do not have a C1 inhibitor deficiency. And the reason for that is that so far we have really needed to rely on genetic markers, on the variants that you just heard of that were laid out very nicely by Dr. Grumach, and Thomas showed you some real life clinical examples of using genetic testing. And so listen, I am all for genetic testing. We should be doing this. We are doing this at our large centers. We're available around the world. We certainly do a lot of sequencing for our patients at our center in San Diego. And we look for these variants that you've just heard about, the 6 that are well described, now a 7th that may be important that Anete described. However, the reality is, at least in our experience, and I talk to lots of you at meetings, I think this is not uncommon, we often do not find these variants. We have a sizable group of people, a rare condition, but of that group with the condition we think have it, HAE unknown is a common scenario. And I can tell you, we sequence pretty much everyone that we're suspicious of this condition. Our hit rate for these variants is less than 10%. In people that we really believe have a very compelling clinical history or phenotype for a non-histaminergic angioedema. And we can talk about, is it hereditary? Is it idiopathic? The line is blurry, but this is a real problem. Genetics have not given us the answer in a subset of our patients. And so I don't have time to go into a lot of details, but of course, we're aware that there's a lot of work going on other biomarkers, non-genetic biomarkers, biochemical markers that might give us an answer as to whether an angioedema is caused by dysfunction or dysregulation of the contact system. So these are just representative manuscripts over the last decade or so, and you can see all the potential biomarkers that are being studied, including and sort of exciting new efforts to measure bradykinin using various techniques that really were developed or refined during the COVID pandemic due to some concern of the contact system being dysregulated in severe COVID complications. So we're hopeful that in addition to genetics, we might have additional biomarkers in the future we can use in the clinic. And again, just a representative publication. This is from Dr. Marceau's group in Canada with a collaboration with many other colleagues, showing that they're able to measure bradykinin and other important kinins in C1 inhibitor deficiency patients where there's clearly a difference compared to healthy controls. In the factor 12 patients, you can see in the table numerically, there may be a little bit of an elevation, but it's hard to discern whether there's a significant difference in these factor 12 patients. And again, these were all patients in remission, not having episodes at the time of the laboratory testing. So there's a lot of work going on to see, can we measure this more effectively during angioedema attacks? Does it hold true for other forms of HAE with normal C1 inhibitor beyond factor 12? Multiple labs around the world working towards this goal of being able to measure something besides a genetic biomarker that might help us in the clinic. And so we stay tuned and hope that we can determine sensitivity, specificity, and validate this in different populations. That being said, until we have a better biomarker, biochemical marker, we are often dependent on these clinical criteria. And this is criteria, the first reference down here, this was an expert consensus from over a decade ago now. So we can argue that this is a bit dated. And in fact, I think Thomas mentioned it. We are evolving in our thinking of the clinical diagnosis, which may include more heavily using omalizumab or other mast cell targeted therapies to really be certain that we're not missing mast cell mediated angioedema, which is of course much more common in the population. But just to quickly run down, this is taken from a New England Journal of Medicine review article, but based on this consensus from 2012. Of course, as you know, recurrent angioedema without wheals, normal C1 inhibitor testing, the documented lack of response to high-dose antihistamines borrowed from the urticaria literature, as Thomas mentioned, and then, of course, the identification of these known mutations we've been talking about, or a family history of angioedema. And then we have some supportive diagnoses that are really either the response or lack of response to targeted medicines, lack of response to epi and glucocorticoids, prompt responses to bradykinin targeted medications, which again, Thomas mentioned, and then clear documentation that there is angioedema, either cutaneous or gastrointestinal. Now, what I want to point out here real quickly is just the reality is many of these criteria are clinical criteria. They're based on history and tracking the patient's response to treatment over time. So the lack of response to antihistamines, the lack of response to epi and glucocorticoids, the positive response to a bradykinin targeted medicine. And so for many of our patients, this also includes taking a family history. And so I would argue that while we have these tests, C1 inhibitor levels, genetic tests, much of our diagnosis in the clinic still relies on taking a very detailed history, assessing the symptoms themselves, the duration, the trajectory, the associated findings like itching or urticaria, the response to treatment, and then of course family history. And while I couldn't agree more with Anete that this is a very important component of what we learn from patients, I would suggest to you that the family history is a very poor criteria for deciding whether someone has a specific diagnosis. We routinely in the United States run into people who are adopted. They don't have a family history. They don't know it. Or their family members have passed away and they don't know their medical history. Or it's unreliable. Thomas shared that, the grandmother that had one swelling years ago, I get that story all the time, and I don't know what to do with that. Was that really angioedema, or was there some other explanation for, their hand swelling up? We also have to recognize the variable penetrance of some of these mutations that have already been described, and the fact that, of course, all these mutations start somewhere. They're de novo. So the fact that a person is the first person in their family to have a angioedema condition doesn't mean it couldn't be a genetic mutation, right? So I think it's very difficult. I would just suggest it's very difficult to be dogmatic, to be too confident that we're making good diagnoses based simply on a family history or lack thereof. So in the last couple of minutes, let me just share with you some interesting data we generated in the US. This was a survey published just last year, an internet-based survey of US physician specialists trying to get at both the prevalence of HAE normal in the United States, but also learn how physicians are going about evaluating and treating these patients. And this was a methodology that used what we call a prescription database. So it's a huge database looking at all the HAE medications that are prescribed, who's prescribing them, and then surveying those physicians as well as physicians involved with the HAE Association. And so this was data was gathered in 2021. So it's a little bit old now, but this is the status as of a couple of years ago. This was the survey that we did. There were over 100 physicians that they looked at the prescription data, and 81 of those ended up completing the survey. You can see they're all allergists, immunologists. Only about a third of them or so were at academic medical centers, a little less than 40%. So many of these physicians were in their own private community practices. And it was separated into what are called high prescribers and low prescribers. And you can see about a third of the prescribers wrote a lot of medications, HAE medication prescriptions, so presumably take care of a lot of patients. In fact, 10% of this physician group wrote about 50% of the prescriptions. So these are the very large centers in this high prescriber group, seeing a high volume of angioedema patients, versus low prescribers that tend to have a few patients, a family or so with HAE. Now, this is the prevalence data, and so I'll just point out this was the raw data, but it's more better to look at these corrections for biases here, and you can see the type 1 and 2 is somewhere between 4,500 and 5,000 patients, and the HAE normal diagnoses around 1,300 in the country if you extrapolate out. The important thing here is that this actually for type 1 and type 2 is pretty much right on the mark in terms of what we believe the prevalence. If you say it's 1 in 65,000, which is what we see in a lot of the epi studies in big European centers, that would be about 5,000 patients, and that's about exactly what we saw. So we believe that the prevalence estimates for HAE with normal C1 inhibitor are pretty good, and in fact accounts for about 15 to 20% of all patients with an HAE diagnosis in the US. Now, what's a little difficult though is that the way that physicians are making this diagnosis varies. And I'll just show you, these are the tests that physicians report using when making a diagnosis of HAE normal C1 inhibitor. As you would expect, most of them are using family history and C1 inhibitor testing. What I will point out, though, is that depending on whether they treat a lot of patients or not, they are more likely to use these responses to antihistamines and corticosteroids. You see the high volume practices use this very often, less so in the physicians that see fewer patients. And for genetic testing, we're really not doing that well in the US. Less than half do any form of genetic testing, and you can see outside of factor 12, very few centers are doing thorough genetic testing. And we could talk about why that is, but access to genetic testing, there are some barriers in the United States. In terms of response to medication, you can see most physicians use icatibant as a good litmus test, but there are some other both acute and preventative treatments, perhaps used by those that have less experience with angioedema evaluation. And then to treat patients after they're actually diagnosed, you can see again, icatibant seems to be mostly used, particularly at the high volume practices. What's a little disconcerting is you can see at these lower volume practices, people with less experience in angioedema, they're actually still using things like antihistamines and corticosteroids, which we as angioedemologists would say, well, that doesn't make a lot of sense if you think someone has HAE with normal C1 inhibitor. And then for long-term prophylaxis, medications like lanadelumab and C1 inhibitor most widely used, although again, you see in the less experienced practices, things like montelukast and other mast cell-mediated medications really being utilized still. So to wrap up, I would contend or suggest to you that while genetic tests are very important and we should be looking at this, they still remain insufficient really to definitively identify or exclude this diagnosis of HAE with normal C1 inhibitor. And in the US, we have really struggled because we don't find these variants very often in our evaluation of patients that have a very good clinical history suggestive of a mast cell mediated angioedema condition. We need better clinical biomarkers. That's an unmet need. And as I mentioned, our recent study suggests that HAE normal C1 inhibitor may account for up to 20% of patients that are seen or diagnosed with HAE, but we do have issues with how we're making that diagnosis, and there remains variability. I would just lastly mention there is a manuscript in preparation that has an international similar survey looking at about 30 ACARE centers that participated, and so that data is very interesting. We still see some variability in how this diagnosis is being made and managed. So with that, I'll wrap up. Thanks for your attention, and I'll turn it back over to Thomas for our question and answer.
Thank you very much, Marc, for this great talk. So I think we heard a lot of very fantastic talks, and we are perfect in time. And the attendees were very active, in the question and answers box. And Anete and I already answered some of the questions, but some question remained. So I think it's still a challenge, right? As you said, to establish the diagnosis correctly, it also depends on the resources and the countries and the centers have. Not all physicians have access to omalizumab or can use it. to treat their patients, and also for access to genetic testing. Yeah, this is also an issue. Not everyone has this good access. You said, Marc, you have a lot of good connections to the Genetic Institute to get these tested. This is all good. Anete and Marc, there are two questions remaining. So, and these questions, to sum up, focus on the new type described on the CPN variant mutation found. And I think me as well, and also the other listeners, were a bit confused that these patients also had wheals. So you talked about urticaria. This is not so much online as we have talked now for the criteria. Yeah, what does this mean? Anete, do we have any? Have you heard about any response to antihistamine treatment, to omalizumab or other urticaria treatments of these patients?
Yeah. I would like to add that they classified as urticaria, not only wheals. So this is difficult to understand. There are some possibilities about pathophysiology in these groups, and I've heard about carboxypeptidase as a cause for angioedema for a long time. So I think that we have to be careful and use the family history, because in this group, they have the family history. They had no response to antihistamine, but there is no report about using omalizumab, for example, in this group. And we have a lot of modifiers reported in some HAE normal C1, and even in HAE with C1 inhibitor deficiency. I realized that it would be a little bit confused coming with this, but this is an idea that we have to use real biomarkers when available, or genetic tests in the family, and also family history. So I think that this is the point. But these families was reported not only in it was 4 families, 16 patients. They did not respond to antihistamines. That's all.
And maybe, Marc, one final question. I think what I learned also from your presentation, we should not be too shy to test patients for response to treatment, right? To the treatments we have available for HAE per label.
Yeah, I think that at least in at our center, that's where we end up a lot of the time, is that we do genetic testing, we do the biochemical testing we can, and we still can't give a good answer as to the mechanism or the pathophysiology. And so we do rely a lot on sort of systematically, meticulously going through treatments, as you outlined in your cases, starting with the mast cell targeted treatments, going up and including omalizumab if possibly now. But if that truly fails, as you noted, using targeted bradykinin or contact system therapies. And I think that, I think the reality is we owe that to our patients, because we need to get them better regardless of, yes, the science we need to work on. We need more research to try to get to the root cause, but we have patients and families that are quite sick and have a life-threatening problem. So I do think, for better or worse, that still remains a very important part of what we do. If I could say one last quick comment, this latest report of the CPN mutation is very interesting, because while I do think sort of in these two groups, the mast cell mediated and the non-mast cell or mostly bradykinin mediated groups, as I diagrammed, the reality is that we see a very small group of patients. It's rare, but we call them in-betweeners, right? They have some mast cell mediated symptoms like urticaria, but they have these very protracted serious angioedema events that don't seem to respond to those mast cell targeted therapies. And so I don't know if this is the explanation, but it's in some ways a relief to see that yes, there is some crossing over, some mixed picture in very rare patients. which makes it harder to manage them. But that's also biology and medicine, right? It's complicated. So I think it'll be very interesting to see where this research goes. Maybe that explains some of these very complex scenarios.
Thank you very much, Marc, and thank you, Anete. And this was already the end of this ACARE Level Up webinar. Yeah, I felt this was a fantastic webinar with very nice comments and yeah, also questions. I enjoyed it a lot. If you wish to have the CME point, please complete the feedback form using this QR code here on the right-hand side. And you already have some new next appointments in your calendar. So I would like to remember that the next ACARE Level Up will take place on the 14th of May with Anke Jindal as a moderator. So it's about the actual treatment approaches in HAE, the perspective of different continents with focus on growth and emerging markets. So do not miss this, but we also have very nice webinars on our sisters sisters webinar. So it's the UCARE Level Up, urticaria and special populations on the 23rd of April and the 25th of June, acute urticaria, current perspective and what key points to consider there. And do not miss the next conferences. So the GAF, the first Global Angioedema Forum, will take place on the 4th and 5th October in Copenhagen. Let's meet there. I'm happy to see you all there. Yeah, and also on the 4th to 5th September 2024, there is the Bradykinin Symposium in Berlin, ACARE Berlin. There's also an angioedema school from ACARE. We are happy to see you and also your physicians there to learn about angioedema. And if you heard about, there's an ongoing project, the CARE, the Chronic Angioedema Registry, the ACARE Registry for all types of recurrent angioedema, where of course you could also include your patients with HAE normal C1 inhibitor to see how they respond to treatment, what their clinical features are, and so on, to follow them up on the long term. Yeah, and also do not miss our podcast, the All Things Angioedema podcast hosted by me. I'm really looking forward to the next episodes to record with nice speakers about topics also you might suggest and you hear and learn about. So thank you very much. If you want to learn more about ACARE and its activities, here's the newsletter, the link, subscribe, and you can get it from the Galen ACARE office as you like. So thank you very much. Let's stay connected in the ACARE Level Up and the ACARE network. I hope to see you all again, also in person in the next conferences. And I wish you a happy day. And in the end, I would really like to thank our sponsors, which make it really possible to run these educational webinars, to connect with each other and discuss about recent advances in angioedemology. Thanks to our sponsors, Takeda, BioCryst, and Calvista, which without them it wouldn't be possible to initiate this with our ACARE network. Thank you very much. I wish you a pleasant day and see you next time. Bye-bye.